Can you hear me?
Yes, we can.
Okay. And we wanted to end the year by discussing a very sensitive topic. And it's a great pleasure to introduce our guest speaker, Camara from Bremen. But first, I want to give the words to my co-chair, Michael McNeil.
Hello, everyone. Good morning, good afternoon, good evening. It is so good to see you all as we celebrate getting closer to the end of 2025. I still feel like it's 2024, so the fact that we're almost moving to 2026 blows my mind. But we're just so grateful and excited to have you all here. It's been a wonderful year for palliative care work, both within PSYOP as well as globally. We've had several wonderful events. Together, both in Amsterdam with the PSYOP conference, but then also the International Children's Palliative Care Network event in Manila just last month, and so much more. And so, very, very, very excited to have Mary here to be able to talk a little bit about her work. She truly is a leader in pediatric palliative care development globally, and just a colleague and a friend, and excited to hear what she has to share today. So, thank you all for being here.
Now, I want to introduce our guest speaker. Camara van Breemen is a senior nurse practitioner and a leader in pediatric palliative care based in British Columbia, Canada. She currently leads the community care and provincial outreach team at Canuck Place Children's Hospice, where she supports children with serious illnesses and their families across care settings. Camara began her career as a pediatric oncology nurse in Texas and later earned her master's degree in nursing from the University of Victoria. She has played an active role in the development of serious illness conversation guides, pediatrics, and is deeply passionate about strengthening communication with families facing life-limiting or life-threatening illness. In recognition of her compassionate leadership, she received the 2025 Courageous Provider Award, and she is known for guiding families through some of the most challenging moments with empathy, professionalism, and care. Today, she will share with us the key concepts and strategies around communication across the trajectory of serious illness, with a special focus on working with families. We are truly honored to have her with us today. Welcome again, Kamara, and the word is yours.
Thank you so much, everyone. So my hope is that we can have some discussion and have an opportunity to share some of our successes and our challenges as that we work with families. So today I'm hoping to get through sort of exploring some topics related to enhancing parents' prognostic understanding and integration of that, discuss a framework that can support two-way communication and medical decision making, and review communication when dying is imminent. So I think we need to start first with sort of this idea and these essential concepts in serious illness care, that we start with respect for the child and parents, accept that there is an ultimate inevitability of death, that we weigh the potential benefits of treatments against the potential risk and burdens. And I think there's few places where we have to do this, more so in oncology and ICU care. Striving to preserve life, but when the burden of life-sustaining treatments outweigh the potential benefits, withdrawing or withholding treatments, and providing comfort in dying is both ethical and good care. This can be difficult because sometimes the laws don't align exactly with what is ethical care and with the withdrawing or withholding treatments. And culturally, we find that depending on where you live and what has been the practice, whether or not it is viewed in a way that aligns with being able to give really good care. And I think the other big thing is that we as clinicians are impacted by patients and family suffering, and that there is we have to take care of each other in this work as well. So I know there's lots of different sort of depictions of how care is across the continuum and where palliative care sort of sits. But I think this idea of early integration of palliative care when there's a serious illness is very important. It doesn't always happen, but we definitely want to strive for that. And I think this idea that we need to respect and embed cultural values and beliefs in care and in our communication, and that we have to promote this idea of effective communication so that families can plan what might happen. So this is an old paper by Chris Feutner, who is well known in his work in collaborative communication. But I think it's very helpful when we think about advanced care planning and when we think about supporting prognostic awareness for families, is that there's different dying um, trajectories and pathways. And so um, along any of these pathways on the y-axis, this could be short days or hours to many years. Other than, of course, when there's more of a sudden deterioration. And really, when we meet the family, it is to support bereavement and grief and um, adaptation to the death. Whereas the other ones, of course, can be a steady decline over a short period of time or even for a longer period of time. And this idea on fragility, where a patient can be very, very sick and then recover and then very, very sick again. And I think about too how this really applies for oncology care, where we can have a child present with a very serious cancer. The treatment itself makes them better, but the treatment can also make them very sick as well. And so along this trajectory, the medical needs may be minimal, they may be complex, they may include maximal critical care intervention, or they may actually be focused on comfort. And the idea that we actually have to work with many, many providers. I'm not going to go a lot into this, but this idea around advanced care planning is really the process of reflection and communication to identify values, wishes, and beliefs of parents. And so we have to always start with assessing the parents and the child's knowledge of the illness, what they think will happen. And we have to share what we know and our imperfect predictions and making recommendations. I just added a link to a good paper that was written around advanced care planning from our Pediatric Society in Canada. Encourage everyone to read this article. It is not pediatric based, but it is this very well written exploring how these conversations around exploring hopes and worries of families and helping them deepen their understanding of where their child is in the trajectory will allow for adaptive coping. And it goes around and around. And the reason we want to have these cycling conversations over time and get away from this idea of, sort of one-time conversations that are kind of in and of themselves along the trajectory, it's a cycling that's really important. And what we know when we do this well is that there's more resiliency and increased quality of life. And actually, parents will choose and families will choose less critical care interventions that are futile. And so this is really, really important work along the trajectory of the illness. Now, as we know, this whole interface between healthcare providers and parents of children with serious illness starts with some sort of breaking bad news, some sort of diagnosis, some sort of, we now know this is why your child is sick. And I do want everyone to really consider and get proficient at doing this really well. And again, Chris Feutner has, this is kind of an expansion on the spikes breaking bad news model, which I think everyone is very aware of the spikes model. But I do like this one in terms of prepare, deliver, and follow up. We know it's really, really important to be forthright and straightforward, and it's very important to provide a warning shot. This isn't asking permission about how much we share or how much, if the family wants to talk. This is about us being a clinician that sits down with a family and we have information that we need to provide. And so those ideas around making a plan, making sure the right people are there, and stating the news simply after giving a warning shot. I have something to share with you from the images that we took yesterday, or from the blood work that is showing some discrepancies in what we normally want to see. Your child has leukemia. And this idea of being able to land that news and allow silence for that internal processing that happens when parents first hear the news. And this is artwork, and this is competency in communication that we need to really take seriously. Parents never forget this sharing bad news, and it can be something that they hang on to that is helpful as they care for their child or in their bereavement, or harmful. So I like to talk a little bit more about how we do this over the trajectory of the illness, and that these cycling conversations over time aren't simply just dropping in and giving more bad news. And how when I go in and see a family that I might not have seen for 3 months and who's been doing very well on their chemotherapy for some time, but I really don't know what they know or what they think, or it might be when I go in and see a family whose child is having a lot more shortness of breath, and they're now have a pleural effusion, but I don't really know what they understand. So this is sort of the construct I use anytime I engage with families in a consult, when I'm checking in with them about symptoms, when I'm actually trying to get them home to their very northern community that doesn't have a lot of resources. This is where I start. So before you report what you know, learn what the parents understand. Tell me why you think she's having more pain. What do you understand about this stage of your daughter's condition? What has your specialist team told you about what's happening now? I really want people to think about, how do I sit here? I know in Canada, when we are often delivering news or having a family team meeting, the med student diligently gives us a report on everything that's happened, often in front of the parents. And although this can be a very good learning for the team, or it can catch up the latest attending, it's actually not helpful to parents. What's helpful to parents is allowing them to speak into the room and to tell them what they think is happening and to update everybody from their perspective. And once we've heard parents, while we're listening, we have to think, do they have an understanding? Like, is it solid? Is it emerging? Am I being able to connect with them about what they understand? Or are the parents actually underestimating how well their child is and are sort of in that gloom and doom state? Or are they overestimating? Where are the parents at is really helpful to us in how we then deliver our information. Yeah, you really are understanding that the shortness of breath is coming from the um, the metastasis to her lungs. Can I tell you a little bit more about some of our planning around what we're going to do for that? So, how do we affirm their understanding, clarify or adjust their understanding in a way that helps them deepen their prognostic awareness? And once you have that dialogue and sort of catch them up or work together and become more integrated with each other's language, what is our plan and support and follow-up? If families are really not understanding what's happening and the child's deteriorating, we need to follow up right away. I'm going to check in with you tomorrow. We have a plan in place for what's happening overnight, but let's again talk tomorrow. If the child happens to be doing very well in their treatment and we're not thinking that there's going to be an abrupt change, what is our follow-up? Is our follow-up in a week or two, or is it another team that's following up? So think of your conversations in sort of these three cycles. Another really, really good uh, journal article about integrating family values is this one. And the reason I really like it is because, when you have someone say, this family really isn't getting it, or they just don't understand what's happening, and there isn't congruence about what the family wants based on how poorly the child is doing and what the team is advising. And this article talks about how do we explore family values and preferences, use the best research evidence, and then have competency and clinical expertise in communication that will allow for the team and the family to come together. And what they learned is that there's sort of four approaches to value integration: showing concern, having competency in decision-making, management, and professionalism, using all of these actually highly attuned communication strategies, and allowing to adjust and tailor to balance and flexible to create this congruence. This is hard work. Um, and this is actually how we can teach other people about communication. Because if you're looking at this taxonomy, you can say, you're doing this part of your communication quite well. But where we need to have you work on as a learner is really in that maybe concern area. So again, I encourage you to think about reading this article. So what I'd love you to do is just think, and you can jot it in the chat if you want. But think about a child you're caring for right now. Maybe you're seeing later today, or maybe you saw earlier. And this idea of what are the 2 or 3 details you know about the child? Maybe it's their diagnosis, maybe where it is you think they are in their trajectory. What we use at Canuck Place, so I work in a setting where we are the pediatric palliative care team for the province. We see children in tertiary centers as well as in 2 different hospices and in community care. And this is the formula I use with my team about when do we get involved, how involved do we get, and whose job is it anyway? So this is our formula. And I'm not, again, going to go into a whole lot, but I want to just point to this idea of we look at how well the child is doing. We have a child assessment. We look at their goals of care. What decisions do parents think is the right treatment plan right now? We consider the family's capacity and how the family is doing, and we call this family zones, and we look at how they're adapting to the illness. Are they understanding? Are they in denial? Are they overcompensating? Where are they at? And we then figure out where the best location of care is and who should do what. And this idea of child zones is very, very important. And the child zone is about, one, the constitution of the child. So how robust are they in terms of their body systems? You have a child with a brain tumor, they actually neurologically might not be super well. Or you have a child with leukemia, but is actually doing quite well immunologically right now because of where they're at in their treatment. This also works for the other diagnosis we see in my work. So we look at the body systems and we think, are they really robust? Are they fragile? Are we on the verge of thinking about ICU care? Or are they ready to go home? And we also think about whether their care needs are stable. What we're doing today and tomorrow are the same things, or unstable. They're needing a lot of suctioning. We're having to give antibiotics. We're having to escalate their pain medicine. And what it does is it looks like this. Is the child stable and robust, unstable, stable and fragile, or unstable and fragile? And there's lots of words that you sort of go, okay, well, I need a little more time to digest this. But I'm going to talk about the orange and the red zones, where the child's care needs are the same every day, but we're worried they might tip over. Or that child who actually have escalating care needs and are very fragile. So caring for a seriously ill child and their families, I want you to think again about maybe the child you just thought about. And what do you think the parents understand about that child right now? Do you know what their current goals are? And I think really importantly, do you know what the family's hopes, worries are, and what gives them strength as their child is becoming more fragile? So we talked a little bit about the health zone and the color the child is in, and of course the care directives. So is the parents' goals live as long as possible, where we're doing a lot of thinking about life-sustaining curative treatment? Is the family in this place where they understand that the child has a serious illness that they're going to die from, but there's still things that they want to do? Maybe not escalate to ICU, but do blood transfusions and use antibiotics for reversible causes or what we think might be reversible? Or are they live as comfortably as possible today? The serious illness conversation guide that Mireille spoke about is something that we use. It's one of the frameworks in sort of getting to the idea around setting up a conversation, not necessarily to make decisions or to create a care plan, but to really understand the family. And I always go in when I use the serious illness to say, hello, family. I am here today to get to know you better. This isn't about us making decisions. This is about me understanding who you are and what your hopes are and worries. And it's a conversation guide we teach so that people can get better, not only at listening, but sharing prognosis. And when I talk about prognosis, I don't mean your child's going to die of this illness. Prognosis means this is what I think is ahead. This is what I think next week might look like. These are the things I'm worried about. This is about me trying to help the parents understand what the next days, weeks, or months might look like so that they can consider their hopes and worries within that context. It's impossible to consider your hopes and worries when you say, yeah, your child is going to die in the next 5 years. That's not helpful. What's helpful is other conversations and other wording. So who are these families you're taking care of? Do you know what gives them strength? Do you know who in their family is a burden to them and gives them distress, or who actually are the very people that help them in practical support or emotional support? So breaking bad news, having conversations, and supporting families is an essential part of how we work. And we do need to do an assessment of the family and how they are adapting to the illness and what is their coping and capacity. So when we think about communication along the trajectory and we realize that the child is fragile, that the child could have a sudden deterioration, the care looks the same every day, but the child could deteriorate. And the child I think about in this scenario most often is that child that has a terrible brain tumor that is close to the brainstem. And this is the child that gets up and still maybe attends school or plays with their siblings and is, on the outside sort of looking okay. and you've told the parents about the MRI and you've shown them the images. But that incongruence of what they see in their child and what how they act in the day can be really, really discombobulating. What we do know in this zone is that we have to do frequent surveillance and assessment, and that we do have to talk about if your child were to get sicker, what would be some of your hopes? What would be some of the things you're concerned about? And what is the best location of care for your child? And similarly, when we actually see a child who is imminently dying, and we are trying to discern whether or not we're escalating care to the ICU, or whether we're actually escalating intensive comfort care. What is our goal in supporting this child, and how do we have conversations that allow the family to choose the path that is of most benefit to their child? Wish, worry, wonder is communication that is helpful. And I've worked with this communication in various countries with different language than English. Because sometimes people say, well, I don't know if that works in my language. I'm not sure. But what I want people to consider is when we use the word I wish, what is the word in your language that would allow for you to align with the family, really hear the family, and say, when someone says, well, I just hope for my child to be cured, for a miracle, what is the language you would use to say to a family, I wish that too? It's not saying you think it is going to happen or you're guaranteeing it. It's that communication strategy that says, I see you. I want that too. So think about the word you can use instead of brushing over their maybe misguided or impossible hope, to say, I wish that too. We enter in with I worry because I worry allows us to be truthful but sensitive. I worry. I worry for your child. I worry for your family. I worry if you go home, this might happen. This is really important. I wonder is the words we use in English that helps us get permission to talk more. And I will as a direct way of sharing our support. So when we have a child with complex medical needs that is deteriorating, determine the parent's understanding of what is happening. Clarify the current goals and what those mean to them, and give a warning shot that there may be a change in their child that the family wasn't anticipating, and that we need to talk again about care and decision direction. Here's an example of how I might use wish, worry, wonder when a family says that they want a miracle. I also hope the prayers work and Jack is healed. Allow yourself to sit in that wonder and that wish. I do worry that the increase in pain and shortness of breath means he's getting sicker despite all you're doing. I wonder if we could talk about a plan if the symptoms continue to worsen, and what is good care for him now. When we deliver our clinical perspective, provide information about the child's fragility. It's really important that parents hear us talk from a function point of view. I noticed that her work of breathing is a lot more difficult. I see that her body is not able to take on calories anymore and she's getting thinner. So talk about what you're seeing in the child's body so that the parents can acknowledge and to see that too. Give examples of what interventions can be helpful and what might be futile. Share what other loving families have done. This is a really important thing. Other families whose child has has an illness such as this or is in this place have done this. This allows this kind of communication about talking about other loving families, distances it a little bit emotionally so that families can think about not necessarily their own child, but what other families have done, so that it's a little more distant from their own emotional burden of just talking about their child. It also helps them understand that they're not the only ones that have been through this, that they're not alone, and that this isn't your first case, that you're making stuff up, but that actually you've shepherded other families. And consider, if you're a trusted person, consider asking if time were short, if these interventions don't work, have you thought about what a good death would look like? Or what would be the most comfortable for your child if time were short? And when we ask this question, we also get to think, to give our recommendations. You know, my hope for your child, if time was short, was that you could hold her, that we would make sure we give you the right tools so she's comfortable. And if families talk about decrease the suffering or focus on comforting, allow and acknowledge, talk about their loving care, provide a recommendation. We never want to say, do you want to do everything? You know, that doesn't help. Provide a recommendation. If a child's heart stops because they have a massive brain tumor, doing CPR will not be helpful, right? If their brain isn't working, their breathing isn't working. So, you know, I'd really like to give you a recommendation around what is best care for her now. And I do not recommend escalating or doing chest compressions if her heart were stopped, because this is really an indication of her natural end. Work with palliative care teams to support symptom management, recognizing that work of breathing is the most difficult symptom to manage, and explore best location of care based on the family's capacity and goals. Although home death can be a beautiful and healing and helpful thing, not all families have the capacity to manage complex symptoms. And so sometimes making a recommendation to stay in hospice or to stay in hospital is the best thing we can do. And again, if we're using the wish, worry, wonder framework, if we're seeing imminent dying happen, I too wish she was not so sick. I know you love her so much. I worry that despite all we're doing, she may die or her time might be short. I wonder if we can talk about care that means focusing on her comfort rather than doing things that aren't going to be helpful. And I'll continue to support you. And we'll ask for extra help from the palliative care team so we can make decisions together. I recommend giving her medicine so she does not feel scared. I recommend allowing her body to show us if this is her time. I know she'll feel more safe secure in your arms. I won't abandon you. I'm going to keep doing ongoing assessment and respond to any distress we see. And I want to bring her loved ones close so we can make memories and connection. The hardest part of our role is supporting families in a different trajectory of care. Many of these families might have gone to ICU before and they see that as doing something. What we have to show is that in a child's dying, we're doing so many things. I often use the word intensive comfort support. Intensive, not lackadaisical, not distance, not I'll hold your hand, but intensive support for the dying child. If you're worried about a child or you're worried about a family and their understanding and we can't quote unquote get them there, really work with palliative care services. grow in your own knowledge and your way of working and communicating. Get good at pain and symptom management, um, and really think about how you consider what your role is in this and how much your follow-up is with the family in supporting them. And that is my talk, and I'm hoping we can have some discussion. Anybody want to sort of, I don't know, bring to mind maybe the family they were thinking about or a family that you've done work with that, yeah, Mike.
No, this was awesome. Thank you so much, and really appreciate your approach with this. And one of the things that came up that I hear every once in a while is, what would you do in my situation? What would you do if this were your child? And I'm curious
Mm.
how.
Yeah, I love that, and I think doctors get that asked a lot, actually, and I think trusted oncologists really get that asked a lot. So I think the biggest tool right there is doing a pause. Wow, that's a big question. Because I think when we allow that pause first and foremost, families will then share why they want to ask you that. And it gives you a more clue about how you're going to answer it. Buys you a bit of time, but it also allows the parents to go, yeah, because I asked another oncologist and he said this. Or I asked another doctor and he wants us to go for this phase 1 trial, and I just don't know if that's the right thing. So always give it back to the wisdom of the parents first. Now, I know that's a bit of a cop-out answer because then they say, no, really, I want you to answer me. And I think being genuine, I think, you know, sometimes saying, I hope I would be brave to talk to my teenager about that, or I hope I would be brave to maybe try the trial that you want to try, but know that if it wasn't working or if suffering was increasing, I would make a different decision and I would pivot. I think if you really believe that moving towards the palliative route of intensive comfort care is the right thing, be brave. Be brave in sharing that. This is a relationship with your families, and I think we can give a pat answer, or we can avoid the question, but we do know that has consequences on the relationship. So, yeah, I don't know, Mike, what do you think? What do you normally do when that happens?
Yeah, so this has happened a few times. I've seen it go very poorly before. I do remember one time where the recommendation of what they would do if it was their own child came from a doctor and it wasn't solicited, it wasn't asked. And so they're like, well, if it was my child, I would do this. And that went very, very poorly. Right. And so definitely it's not something that we should do regularly. My normal response is, that is just like you said, that is a really, really powerful question and a hard question. Because to be totally honest, I don't know. I can think now, and with my medical expertise, I could come up with some sort of solution that I would do if that I were in that situation. But I don't know what would happen if I ever were to get to that situation. All I can tell you is what I know from my medical experience and what I've seen other families do. And I think it goes back to what you talked about earlier about seeing what other families have done in these situations and say, I've seen families make the loving decision to do this and to do this. And so but to be totally transparent, I don't know what I would do. And I wouldn't want to impose my own beliefs on you and your family, but hopefully work together with you, knowing you all and knowing what I know from a medical side so that we can come together and make the decision that is right for you and your child. So again, maybe a little bit of a cop out, but also just kind of a recognition that, I don't know what I would do.
Yeah, and I think what you're saying is you're giving permission for them to keep exploring, right? You're not shutting it down. You're saying, let's keep exploring. So, yeah, beautiful. Other comments or thoughts?
And thank you, Camara, very much because you provided us a really realistic and compassionate perspective. I want to make a comment and then ask a question while we're waiting questions from the audience. I think patients and their parents need ongoing hope to cope with the everyday life while they are having a seriously ill child. And in our own research paper, we found that the hope did not disappear. It just transforms from hope for cure to hope for comfort. And I want to ask you that how can healthcare providers maintain hope while still being honest and realistic?
Mm. Um, yeah, I did a little clip about hope. I don't know, it was a while ago for Canuck Place, and I'm actually a firm believer that hope. I can neither give or take away hope. I mean, I can say things that are mean and not helpful, but I really believe that hope is from the soul or from the spirit, and that humans are absolutely remarkable people and can live in the most hopeless circumstances and yet love and connect and have relationship that fills them. And so, I think it is for us, it is about opening that space for them to wonder and to consider different hopes. And obviously, hope for cure is where they start, and we hope alongside them. And again, over my many-yeared career, um, hope for another smile, hope for um, um, a squeeze of the hand can
Mhm.
be what happens. And so I try and be very two things. When families are in that place where someone might chart they're hopeless because they sob and they cannot get words out and they're what we see is devastated. What I try and do is give them grace that they're incorporating what they wish didn't wasn't happening. So give that grace, stand alongside, check in on them, and see what grows from that. And allow them to share what grows from that. Because sometimes they're scared to share their hopes because they've been shut down or we don't sort of believe that can happen. So have that grace to say, when the family says, and now she's going to die. Yeah, she's living right now. What is your hope right now? And allowing that space for them they'll shift. Yeah, we don't have to insert it. We just have to give grace. Yeah.
Thank you very much. And I'm looking, is there any questions? No.
Regine,
Um,
I'm
Hi,
not saying it right, I'm sure.
hi, Camara. Thank you for this beautiful and very important presentation, very touching. Also, I had to leave from some minutes because I had a patient. However, I mean, it is really a very important topic. Now that we were talking about hope, maybe Mirai has told that we work together with Mirai, and I'm proud of her being my mentee of Mirai. And we had done some studies, some studies in our center on hope, on at the end of life, the place of death that the parents want to say, the taboo words that they don't want us to say, and there are cultural differences, although the emotions are all the same in the globally, but there are cultural differences in expressing the diagnosis, the end of life word. But we have to be, as you have said, very. We have to give space for them to share their thoughts as well, and the hope is very important. We had also done this. One of the studies was on the hope from the parent side and also from the physicians and other healthcare professionals, the nurses side also. Everyone needs a hope to go on. It can be, as you said, it can be a hope for cure, which most of them will have. But even if they know that they will die or they are really at the end of life, they don't want it to be told to them every day. And they want the hope to, as you say, to touch the hand, to live a week more, a day more. And so I think this is very important to share, to know that, to tell always the truth to the family, to the parents, to the children. We always have to say the truth to the parents. To the children, it is sometimes culturally different because most of the parents, like in Turkey or in this part of the world or in the Middle East, would not like the doctors or the healthcare professionals to tell the child that they will die. And this is really, there's even sometimes it is hard for them to accept, even to tell the diagnosis to the child that it is cancer. So we have to tell the cancer and that it is cells that are growing without a control and so on. And it takes time until they say, okay, now we can use the word cancer with the child. And we have to respect it. But otherwise, to have a good compliance from the families, we have to respect their what they want also, because otherwise we cannot have we have to be together, the healthcare professionals, the family, and the patient. We cannot ignore their thoughts or their wishes or their cultural beliefs as well. But the hope, as you say, is very important, and that was from both sides, from the parent side and the healthcare professional side, to have the hope. It doesn't mean hope for cure, but the hope for one more day, for one more hug or whatever. I think this is very important, and I appreciate that you have mentioned about it.
Yeah, thank you. Thank you
Thank
so
you.
much.
Thank
A
you.
whole nother talk on talking with children and connecting children with their parents when communication is difficult. And I appreciate you mentioning that. I'm also a play therapist, and so working with children, as we know, they often know, even though we don't say it. So how do we create that connection to what they know and what their understanding is so they don't feel as isolated is super important. I love that you said not talking about dying every day. That is so important. I think there's a misunderstanding about people thinking prognostication is you're going to die, you're going to die, you're going to die, and somehow that creates family readiness. It doesn't create family readiness. It's actually harmful. And what I often say, and patients like they kind of get blown away, one of this a young, she was about 12, and she got more bad news about her cancer, and she says, Camara, am I going to die? And my brain says, yes, you are. My brain says that you're going to die. We can't, like, this is terrible. And she's absolutely hysterical. And I said, let's breathe. I said, can I tell you what I think is happening right now? And she said, yeah. I said, you're not dying. You're living. Look at how your lungs are working. Look at how your brain is working. Look at how you're talking to me. So for me, hope is about reminding people they're living, and that our job in palliative care is to make their living better, not worse. We don't want them to want to die. We want them to want to live. And so I think this idea of you're living now, and what are we going to do today is really about fostering hope.
Yeah.
Camara, one thing that in 1992, when I was a visiting fellow in the United States, one of my mentors, Jonathan Finley, he's a neuro-oncologist, because in Turkey, usually, even today, most of the patients do not ask whether they will die. I think this is something cultural because they don't want to accept it themselves, nor their parents. So they don't usually ask that. There has been very few adolescents that had asked me during my 40 year of career. And so one of the relapsed brain tumor patients asked Dr. Finley, am I going to die? Because it was a relapsed medulloblastoma and the chances were low and so on. And so he asked directly, am I going to die? And Dr. Finley said, well, every one of us will die one day. We don't know when. The most important thing is that we live with quality of life the days that we live. In fact, that was really a very good answer that I learned a lot from.
Mm-hmm.
Yeah.
Mm-hmm. Absolutely. Yeah. Thank you so much.
You're welcome.
Any other thoughts or questions or comments?
Wonderful. Well, thank you so much for being here today. We so appreciate it. I think it looked like Mariah was having some technical difficulties and just fell off the call. But just another huge round of applause for taking the time, especially as we approach the end of the year, to be able to talk about such an important subject and for us to really, again, just remember hope, and compassion, and really recognizing who we're doing this for. And so thank you again for all that you do. And I hope the rest of you have an incredible end to 2025 and an amazing start to 2026. And we will be in touch soon. Take care, all.
Bye-bye.
Thank you. Happy holidays from now.
Take care.